All right. Let's squeeze in there. Yeah. All righty. I'm Erin. I'm an athletic trainer with PT at ACAC.
Hi, I'm Brooke. I'm a physical therapist with PT at ACAC.
So we're going to talk a little bit about concussions and the latest research and kind of what we each do when a concussion comes our way.
So we'll share screen, which is right there, the middle, the green. Yeah. And then you'll, definitely. Don't click it through. And then,
All right. Sorry, bear with us here. All right. So concussion management from the field to the clinic. So just starting off with just a little bit of epidemiology about concussions. So it's difficult really to estimate the number of concussions or TBIs that occur each year, just because the injury and the rate is defined in so many different ways just based on the organization that's defining them. Some organizations define a concussion as one that's reported and diagnosed in the emergency room, whereas others define an injury as one that's seen in the sports medicine clinic and then results in absence from play or participation. Others, again, base an injury on the symptoms that are reported by the patient, but listed on this slide here are just from the CDC in 2014 of the ones that were reported to the emergency department. So you can see approximately 2.5 million traumatic brain injuries are related to emergency room visits, and then 812,000 are those among children. 288,000 of those are related to hospitalizations, and then 23,000 of those occur among children. So then what exactly is a concussion? The CDC defines a concussion as a type of traumatic brain injury, or TBI, caused by a bump, blow, or jolt to the head, or by a hit to the body that causes the head and brain to move rapidly back and forth. The sudden movement causes the brain to bounce around, twist in the skull, creating chemical changes in the brain, and sometimes stretching and damaging the brain cells themselves. So many used to think of a concussion just as a brain bruise or bleeding, a small bleed in the brain. But we've learned through recent research that it's really the result of those chemical and cellular changes that occur.
So just a little bit more about the pathophysiology of it. So a concussion is an acceleration-deceleration injury. So there's a rapid movement of the skull, which causes the brain to sort of slide around in the skull. So when that happens, the brain sort of changes shape. If you sort of think of a Jell-O mold sitting on a plate and you move that plate, the Jell-O is going to wiggle, and that's sort of what your brain does in the skull. So as the layers glide over each other, when that happens, you can get some shearing or some overstretching of the axons there. So in most mild cases, it's just mild overstretching. In more severe cases, with traumatic brain injury, there can actually be shearing and tearing of those axons. The axonal shearing or stretching sets off a neurometabolic cascade as the membrane deforms, and so there's ion exchange that occurs, and that ion exchange causes a depolarization to occur. So when that happens, the neurotransmitter glutamate is released, which creates more action potentials and causes more continued depolarization of the cells, which creates sort of this electrical storm in the brain. So when the injury initially happens, there's a lot going on in the brain. That's known as sort of the excitatory phase of a concussion. So when the brain is overstimulated like that, initially when you come across an individual that's had a concussion, that's why they're confused, there's some disorientation, maybe some dizziness, but that's part of why they feel that way, because there's a sort of overstimulation in the brain. And that happens pretty immediately and can last for a couple hours after the initial injury. Because of that release of glutamate, it actually activates the calcium channels, and the calcium channels get into the cells and actually block the production of energy. So the body's working really hard to correct that ion imbalance, and that uses energy and requires ATP for that. However, the calcium is blocking the supply, so there's an increased demand but a decreased supply. So that is in the days following a concussion, why an individual would feel really tired and fatigued because they don't have that energy supply to help sort of fix the problem there. So that disparity between the glucose supply and demand triggers a cellular energy crisis. And it is thought that energy disparity is the reason for post-concussion vulnerability, making the brain less able to respond adequately to a second injury. So that's what's known as second impact syndrome, when you get that second injury before the brain is fully healed from the first one. That calcium accumulation can continue for a few weeks, but it does get better. So a concussion is really a functional injury versus a structural injury. So early on, when if somebody goes to the emergency room after a head injury, if they do imaging, it's just to rule out any major problems, bleeding in the brain that need to be addressed right away. But for the most part, for a mild concussion, there's nothing that's going to show up on the MRI. That's because there's not really that structural damage that has occurred. So during the period of decreased cellular metabolism, there's a lot that does happen in the brain. So there's decreased cerebral blood flow, there can be altered autonomic nervous system responses, increased inflammation. So that's why those symptoms can continue for a few days after the injury. Once the energy crisis resolves, those symptoms will improve and get better. If an individual has more persistent symptoms after that, likely there's something else going on. It could be something related to the vestibular system, visual system, some cervical dysfunction. That is where physical therapy can be really helpful. One other thing to mention is you cannot always go by patient-reported symptoms. So when we're talking about, we'll get into this a little bit more later, but returning an athlete to sport, they can't just come in and say, well, I feel better, and that means they're ready to go. So we'll talk about some of the things that we look for to ensure that they truly are ready to return. So as I was saying, you need to see that sort of metabolic recovery, not just the symptom recovery. So there's good evidence to show that usually occurs within 2 to 4 weeks after an injury. However, it can take longer. It just depends on how the injury is managed in the first few days after it occurs. As Erin, actually you didn't get into your testing stuff yet.
No, not
We'll
yet.
get back to that, sorry. So anyways, there's a need for comprehensive testing. So we'll look at, Erin will talk a little bit about the neurocognitive testing. We look at the symptoms, we do some physical exertion testing to see when they're ready to return to sport.
Alrighty, so concussion in sports. So as an athletic trainer, we see concussions on the field a lot. So in recent years, our concussion testing has grown immensely. To when I first started, we didn't really even have a concussion policy in written form. So that's something that we have worked really hard on. And we definitely didn't do any baseline testing when I first started with PT at ACAC, almost 13 years ago. So we're gonna kind of dive into this. So just incident rate per sport. So these are always kind of interesting numbers to look at. The numbers on the screen here are both high school and collegiate athletes combined. So if we break that down just a little bit more, it's important to note that a lot of sports-related concussions actually go unreported because the symptoms can vary so much, and athletes, for various reasons, don't report them to their athletic trainer. They may think, oh, it's just I just have a headache after practice, or oh, that's nothing to tell my athletic trainer because they're going to hold me out. So we really try to do a lot of education to break that. But just a little bit more data. According to UPMC, University of Pittsburgh Medical Center, roughly 50% of sports-related concussions actually go unreported. 2 out of 10 high school athletes who play a contact sport will sustain a concussion this year. Girls soccer is actually the second most reported concussions in all of high school sports. And of the 1.7 to 3 million sports-related and recreation-related concussions that occur annually, 300,000 of those are football-related. So that's a good chunk of them. All right, so as the athletic trainers in our sports medicine team, who's administrators, who's our team physicians, to sports psychologists, everybody that works on that sports medicine team with us, we all work together. It's really a team approach to keeping these kids safe on the field. So from equipment fitting and making sure and working with the coaches, to make sure helmets are fitted properly and nobody's swimming around and their helmet's not going back and forth before that first day of practice, to making sure everybody has a mouth guard in, to the proper use of padding. We're out there at practices, so making sure practice techniques are safe. Again, we educate preseason. We have parent conferences, a preseason athletic meeting, and where we talk about concussions and the importance of reporting even those most minor seeming symptoms, because even those minor ones can turn into something major if not reported. And then again, we do the baseline and then post-injury testing, which we'll get into here in just a minute. So the baseline testing really provides us with the vital information of an athlete's normal and healthy brain function prior to receiving a head injury. So then we can see where the deficits lie after they receive an injury. So listed here are some various testing systems. There's a lot of different computerized exams that can be used. With Albemarle County High Schools, we use IMPACT as our computerized neurocognitive exam. We use the BEST test, which is a balance error scoring system. SCAT-5 is a sideline concussion assessment tool, which can be used post-injury, immediate post-injury. Concussion vital signs is another computerized neurocognitive exam, which is very similar to IMPACT. And then the King-Divic is a computerized exam used on a tablet computer, but it more so recognizes the impaired eye movement that can happen after a concussion. All right, so what do we use? So we are contracted with all the area high schools, all the Albemarle County high schools, as well as CHS, the Covenant School, Tandem Friends School, and the SACA organization. So at all our high schools, we use IMPACT. So every kid that is in one of those contact sports, it's open to all athletes, but all the contact sports have to take an IMPACT baseline test. IMPACT is, again, the computerized neurocognitive testing platform, and then it utilizes the athlete's visual and verbal memory, visual motor speed, reaction time, and then impulse control through a series of 6 computer-based modules. IMPACT is administered during the first 10 days after a team roster is chosen, and then again given post-injury to monitor the healing process and aid in the return to play decisions. And then the BEST test, again, is the balance error scoring system. It's administered again at baseline to measure postural control and stability. The test consists of 3 stances, timed for 20 seconds each on 2 different surfaces. So then again, the test is repeated post-injury to monitor their athlete's progress and for return to play. The SCAT-5 is a paper and pencil test or assessment that we use on the sideline. Just helps in the immediate evaluation and assessment for a concussion. It's not a diagnostic tool, but again, gives the athletic trainer kind of an idea of where the athlete stands on a symptom scale, the evaluation of immediate memory, concentration, delayed recall. It also has a modified BEST assessment included in the test, a tandem gait assessment, and then the finger to nose coordination test. Another tool that we use is the graded symptom inventory. So we use the graded symptom inventory a little bit sparingly because, as Brooke said, we don't want athletes to get too symptom focused, but it is a nice tool to track where athletes are on the symptom scale, both immediate post-injury and then a progression or regression of those symptoms as they go through that healing process. And then finally, the time tandem gait is similar to the BEST test, but it's easier to do on the sideline. So that's why we use it a lot. It's essentially just walking heel to toe for a time distance. A concussion positive athlete will perform a test at slower and less coordinated pace, and they'll spend more time in a double leg stance. So then we get into the return to learn. So we really try to make a really important emphasis on this return to learn. So it's something that's kind of come over the years, kind of changed as we've gone along and learned more in this concussion assessment. So oftentimes it started as a communication between the doctor and the athletic trainer, and then it's then communicated to the appropriate educational staff by the athletic trainer. Students progress through the stages at varying speeds. They can stay at a stage for days or weeks. You know, it really kind of depends on where they are. We really put an emphasis on getting the athlete back to full academic participation before they even, before they would go back to athletic participation. So as you can see, they're broken down into stages or color-coded, just aids in the communication. They each have their own, I won't read through all these with you. They each have some, you know, recommendations for where the athlete should be in the classroom. So these are stages 1 through 3, and then 4 and 5. So 5, you can see where they go back to a full symptom-free day of school. All right, and then we get into the return to play. So versus the return to learn, the return to play is, it's really important that this is a supervised stepwise progression. So whereas the return to learn, you can skip from, say, red to green. The return to play is, it's really important that we go stage 1 to stage 2 to stage 3 and so on. So the initial period, we do a 24 to 48 hour of relative rest. You know, it used to be the thought that you sat in a dark room by yourself in the quiet until you're totally symptom free. And that's kind of gone by the wayside with more research that we do this, you know, relative physical and then cognitive rest with, you know, stage 1 being symptom limited activity. So they're getting, you know, athletes are getting back to like some walking and some ADLs, and they're getting, you know, reintroduced to school activities. And then, you know, we progress through these, spending about 24 hours, at least 24 hours with each stage. And then, you know, finally then returning to full sport and game activity.
So when does an injured athlete become a patient in the clinic? So that's where I step in. So it is estimated that about 1/3 of children and youth sustaining a concussion will take more than 4 weeks to recover. This is, I think, usually without good management at the beginning of the injury when it initially occurs. So the other 2/3 that are working with the athletic trainers and the coaches and sometimes the physical therapists will move through those return to learn and return to sport stages, you know, ideally a little quicker. So some of the things that influence the recovery time include the individual's age. Females are more likely to sustain a concussion and more likely to take a little longer to recover than males. If there's any kind of psychiatric history, if there's any vestibular dysfunction or oculomotor dysfunction, usually those folks take a little bit longer to recover as well. If there's a history of migraines prior to the injury, and if their symptoms are pretty severe from the start. The individuals that have prolonged symptoms likely have some other things going on. Like I said, the vestibular and oculomotor dysfunction, and quite often some cervical dysfunction. If you think about how a concussion is sustained, it's sort of a whiplash type injury with that brain moving around in the skull. And so there's of course going to be some movement at the neck and likely some cervical dysfunction. So that's where, you know, physical therapists can be helpful. So just briefly to look at this cross-sectional review, this is from a clinic that specializes in concussion treatment. So they looked at pediatric patients ages 12 to 14 at the initial visit, did the concussion symptom scale, impact testing, like Erin mentioned, and VOMS, which is the visual ocular motor screening exam. So they excluded some of the more severe injuries, or if they had a pre-existing vestibular disorder. recovery was considered full clearance for activity, so back to baseline, and no symptoms at rest or with exertion. So they looked at the recovery time in two different groups. So those that took less than 30 days to recover and those that took more than 30 days to recover. They also divided up the individuals into, can you switch to the next one, into two groups, so sort of the early presenters and the late presenters. And they found that the greatest predictor of recovery time was actually how long it took them to get into the clinic in the first place. So, you know, again, that just goes to show that earlier intervention can, you know, significantly improve how quickly they can get back to sport. You know, again, I think the thought is with that likely if the individual is taking longer to get into the clinic and taking longer to recover, that some of the initial treatment was sort of counterproductive, meaning they were probably limiting screen time and in a dark room and, you know, doing all the things that, you know, used to be advised after concussion, but that research has changed a little bit over the years. The next one, again, I will kind of go through it quickly, but again, it's just another study that shows the length of time for recovery. So they looked at, go ahead and switch it again, 115 out of 264 participants were included. Again, they found that with the two groups, the only significant difference between the groups was as far as how quickly they recovered, was how long it took them to get in for that first clinical visit. So just another reason to advocate for earlier intervention. So concussions are really scary. You know, as Erin said, if you focus on the symptoms a lot, an individual can get really sort of nervous about what's going on, and that contributes to the anxiety and depression. And a lot of those symptoms actually are very similar to post-concussion syndrome. So, you know, if somebody really has a lot of anxiety, that's something that I try to kind of talk them through and help them through. Because those symptoms can overlap a good bit. So educating the individual can really empower them to help them feel like they have some control, and they actually have an active role in their recovery. So what do we do in physical therapy to aid in the recovery? So usually at that first clinical visit, you know, they fill out some kind of outcome measure so we can kind of get a good picture of how they're feeling overall. Then we'll take a detailed history, including like the mechanism of injury and what they've been doing since the injury occurred. I'll screen for any red flags, you know, assess cranial nerves, assess for neurological signs, assess cervical spine for damage, if I feel that that's warranted. There's a time, again, like I said, when there's a lot of stress due to just how anxious the person is about the injury. They're also missing out on their sports, so missing out with social time with their friends. They're missing out on schoolwork. I've found with a lot of the high school kids I've treated, especially, they get very worried about what they may be missing in school and worried about falling behind. So again, when they get sort of anxious and that depression sort of sets in, a lot of those signs mimic those of a concussion. So exercise is actually really helpful to help combat some of that. Like Erin said, we try and encourage early activity because there's really good evidence for exercise to help keep those symptoms at bay. I also provide a lot of education on sleep health and nutrition, and you know, all the active ways that an individual can you know, sort of help themselves recover a little bit quicker and feel like they have some control over their symptoms. Okay, change it. So usually that first visit is a lot of just education on what's going on and what they can do to start sort of managing their symptoms a little bit better. At that second visit is when I dive a little bit deeper if I feel like there's some oculomotor or vestibular dysfunction concerns, and start addressing those. Treat any cervical spine impairment that I may have detected. And then we often do some treadmill testing so that, you know, like we've been saying, exercise is good, but how much is too much and how much is an appropriate level. So that's something that we actually do in the clinic and can give an individual a very specific, you know, heart rate range with what they should exercise in. So as we've said, the advice to rest is no longer the best practice. So just a little bit more on the treadmill testing. So we use the Buffalo Concussion Treadmill Test. So basically, it's a protocol that assesses the patient's symptoms in addition to their physiological response to exercise. So there's really good evidence that even in the acute stages, subsymptomatic exercise can decrease recovery time. There's some thought that it may be the increased blood flow to the cerebrum. It certainly improves the emotional and physiological outlook because the individual is being active, so especially for an athlete that's used to working out hard and pushing themselves, to tell them they can't do anything but, walk is a little bit stressful for them. So we kind of, make sure we give them a few different things that they can do, and in very specific numbers to look at, and so they know how to progress that over time. So with the treadmill test, so we set the treadmill at a certain speed, 3.2 or 3.6 miles an hour, and then we gradually, and that depends on the person's height, and then we gradually increase the incline. And while we're doing that, we're monitoring their perceived exertion of how hard they're working. We're monitoring heart rate and just their symptoms overall. And if there's more than a 2-point increase in their symptoms, based on the scale that we showed them, then that's when the test ceases, and that's when we calculate the heart rate that they're at that time. And then their prescription is to exercise at a certain intensity of that. So it's recommended to do 20 minutes a day, most days of the week, at 80 to 90% of that heart rate that we calculated during that test. And then, knowing that they can increase that depending on their symptoms, every 1 to 2 weeks, I think, again, just helps them feel like they're doing something active and have a little bit of control over their recovery. So just a little bit more on the benefits of exercise. So we talk about some of the things that happen in the brain. So, concussion can alter the control of the autonomic nervous system. It can lead to decreased cerebral blood flow. Exercise can help with all of that. So it can help restore the autonomic nervous system balance. It can help an individual return to normal exercise tolerance because they're going to get deconditioned pretty quickly. It promotes neuron growth and repair, and it mostly just improves their mood and decreases the stress and anxiety during their recovery. So to follow-up visits after that, if somebody needs to continue with PT, it's mostly just continued symptom monitoring, checking in with them how their exercise is going as they're gradually progressing. Continue to treat any of the musculoskeletal injuries that might be involved, the visual and vestibular therapy if that is indicated. So there's just some different balance treatments we can do, or vestibular treatments we can do to help with that stuff. And then we gradually progress their activity. So you start with walking or a bike where there's sort of minimal head movement, and then we gradually progress to something like running where there's more of this movement of the head, because that's going to test their visual and vestibular system a little bit more. So as long as they're progressing with that stuff and their symptoms are not progressing, then we know we're on the right track with them. So for an individual that just has symptoms that don't seem to be improving with any of that, that's when I would consider referring to another specialist. So the biggest key, I would say, is the communication with athletic trainers at the individual school. So when I get an athlete that's injured, quite often their athletic trainers reaching out to me, letting me know what happened and seeing when we can get them in the clinic. And then equally, I communicate back with them, what my observations were, what our plan is in the clinic, and then also what our prescription is for exercise at that time. And we work together with athletic trainers at the school, because that's where the athletes will be perhaps doing a lot of the recovery and the exercises when they're at the school, because it can be around their friends, it can still be around their team, and be walking around the track while their team's practicing. So that communication with the athletic trainers at the school is really, really important. So we talked about the Buffalo Concussion Treadmill Test, and it's a great tool for giving an athlete sort of a prescription for exercise, and it's great in early recovery. And then it's designed though with sort of straight plane activity. So like I said, they're when you're walking or when you're on the bike, your head's not moving very much. So it's not a great test for really determining if the individual is ready to return to sport, because sports involve a lot of bigger movements and turning and pivoting and moving up and down. And so that really puts much more stress on the visual and vestibular system. So another physical exertion test that has come out recently is the Gapsky-Goodman test. So that was developed by the Chicago Blackhawks medical staff. And it combines alternating the aerobic and anaerobic exercise, as well as more sports-based vestibular and visual challenges. So again, another study really quickly that looked at, it was from that same concussion specialty clinic, but they looked at a bunch of athletes that all were asymptomatic at the time that they did this Blackhawks test. So that means they had already done well with the Buffalo Concussion Treadmill test. They were asymptomatic at rest. They were asymptomatic with exertion activities. But they put them through this test, which is a little bit more challenging for them. And even though all of them went in asymptomatic, 14.6% of them experienced an exacerbation of symptoms during that test. So, I think that just goes to show that, we really need to make sure that we're testing them at the level that they're going to be returning to their sport, to make sure that they have made a full recovery prior to letting them do that. We're going to talk a little bit more about the Blackhawks test, actually, just so you know a little bit about what is involved with that. So you put the individual on a bike doing sort of a lower RPM and then also a higher RPM, and you're alternating back and forth between that, plus activities such as like hopping over hurdles or jumping up onto a box, forward lateral jumps, burpees where they're going down and then kind of jumping back up. So it's really stressing their vestibular and visual systems, like I said. So overall, the return to play decisions should be multifaceted. So it should involve the neurocognitive testing, like the impact test, the physical exertion testing that I've mentioned. I think a big thing to consider is the number of concussions an individual has had. And not only the number, but how those previous concussions were managed as well. And then the individual readiness to return. If they're feeling really nervous about it and anxious about getting another injury, that's really not a good individual to go back to sport. That's somebody that may need some more help, either with PT, that we continue to push them a little bit more and to build their confidence up, or maybe they need some more counseling to sort of help overcome that anxiety and depression. The biggest thing, again, I said, is the communication between athletic trainers and the physical therapists is key, just to make sure we're all on the same plate when it comes to getting that individual ready to return to sport. That's it.
All right, so there's just some resources, some extra resources and citations of articles that we used in the presentation. So any other questions, feel free to type them in the chat and we can answer those.
Thank you guys for attending.
This, just a reminder that this will be recorded, so we will put the recording on our YouTube channel, which has a lot of great resources there as well. And I can also provide, email information if you guys want to reach out with any questions later. So yes, so thank you all for attending. And I guess if we don't have any questions, oh wait, do we have one?
You find doctors in our area prescribing you
Yeah.
to the concussion.
Oh, we
care.
got some.
I would say that it's a mix. I think I still hear some that prescribe rest in a dark room and no screen time. We've tried to reach out, especially to some of the pediatric doctors in the area, knowing that we had our athletic trainers out at the different schools. So I've been to a couple of the pediatric clinics to talk about what we do in physical therapy. So definitely those doctors are more on board in sending folks to us. Any thoughts on that?
Yeah, I mean, it's something, again, goes back to the education piece. It's the more, I really feel like what Brooke was saying, the more we educate, even starting with the parents, the more that we educate the parents in the schools, and, bring it more to the forefront that PT is an option, that we're seeing more of those referrals into the clinic. Any other questions? As Angela said, she can share our emails if anything comes up later, if y'all have anything else. That can cause continued dizziness if the ears are okay, according to the doctor.
There's actually a lot of things that can cause continued dizziness. So saying that the ears are okay is sort of it kind of depends on what the doctor was looking at and looking for. So there can still be an inner ear problem. So one of the things that happens with, a fair number of concussions is what's called BPPV, or benign paroxysmal positional vertigo. So basically when it's, when your brain gets knocked around, there's all kinds of things that can happen. And so that has to do with sort of the fluid in your ears when you move that gives your brain information about how your head is turning, and things can get dislodged and float around in that fluid with the head injury, and then that confuses the brain as to where you're looking and where your head is moving. So that's actually something that's very treatable in PT, because you do these maneuvers to kind of get all those crystals back in the right spot. So that's certainly one of the things, but also a lot of cervical dysfunction has been shown to cause dizziness. So that's what I see probably a little bit more of, that there's just still some cervical dysfunction that is causing a lot of those prolonged symptoms. It can be dizziness, it can be even the brain fog that a lot of people describe after concussion too can come from cervical dysfunction. So as I said, the injury to the brain itself actually heals pretty quickly once that energy crisis heals or gets better. It's those lasting symptoms are usually from something else. So vestibular, some visual issues can cause some dizziness as well if your eyes are not able to stabilize your gaze very well. So there can be a lot of things. I hope that helps.
All right, and then recommendations for continued headaches.
Again, I think that really could be related to cervical spine. When some of the muscles in your cervical spine, so especially suboccipitals that sit right underneath the occiput or the skull there, those muscles are activated as soon as you go to, even just turn your eyes. So when you're laughing and when you're moving your head and doing any of that stuff, those muscles are active. And the nerves that innervate some of the skull sit right there in those muscles. And so those, when you have trigger points or those muscles are really tight, they will refer symptoms sort of into the temporal area. So that, that's my thought is probably what's going on with something like that when you're laughing or bearing down, that maybe there is some cervical dysfunction that is causing that. Absolutely. Thank you all for attending. Anything else? Cool.
All righty.
Thank you very much.